everyone, and welcome to the Disability Networking Zone. This is the zone's first session where we will be delving into the future of HIV and disability research. So we'll be looking at research that either has already been conducted or is being conducted here in South Africa. Just a quick introduction to myself. My name is Jacquli Kaschula. I'm an intern and project coordinator at a Freak Rehabilitation and Research Consultant, which is a non-profit company operating in South Africa. I got my bachelor in public health last year, 2019, and am planning to do my MSc in epidemiology. Unfortunately, because of COVID-19, next year, 2021, in Europe. I'm going to give a quick introduction just on the presenters that you'll be meeting, the research that they'll be going over with you guys, and then also just a quick little bio on each presenter so you know where they're from, what kind of research they're looking into, their qualifications, etc. So the first category of research that we'll be looking into for this session is prevention. So research that's largely focused on prevention. The first presenter you will be meeting today is Sonti Pilusa, and the title of the research that she'll be going through with you guys is Knowledge and Behaviour Regarding HIV and AIDS Among Persons with Disabilities in Gauteng, South Africa. A little bit about Sonti Pilusa. She is a lecturer at the University of Witwatersrand, which is here in Johannesburg, South Africa. She is responsible for teaching community physiotherapy and public health at undergraduate and postgraduate level. Sonti's main research interests are in health promotion, prevention of diseases, and health related to people with disabilities. The second category the session will be covering looks at research mainly focused around intervention. The first presenter you guys will be meeting is Professor Ronel, and the title of her research is Encouraging Movement and Functions to Influence Disability. A little bit about Professor Ronel. She has her PhD, MSc, and DSc in physiotherapy and is an associate professor at the University of Witwatersrand. She was a clinician for 12 years prior to joining the physiotherapy department in 2009. She practiced as a physiotherapist in South Africa, the United States of America, the United Kingdom, and Saudi Arabia. She is a member of the South African Society of Physiotherapy, the Critical Care Society of South Africa, and People for Awareness of Disability Group. Her research interest is rehabilitation and exercise of individuals with cardiopulmonary impairments and physical function limitations as a means of influencing disability. The second presenter you guys will be meeting under this category is Precious Molousi, and the research she will be covering is the identification of components of a comprehensive disability rehabilitative program for adult people living with HIV, a scoping review. A little bit about Precious Molousi. She is a clinician at the Z-Rist Hospital here in South Africa. Her interest is in community rehabilitation, and she completed her master's degree in physiotherapy at the University of Witwatersrand. The third category we will be going over is research looking into, or largely encompassing and focusing on, pediatrics. The author and lead presenter you will be meeting here is Professor Joanne Potterton, and she will be going over research entitled Growing Up with HIV Challenges Through Childhood, from Infancy to Adolescence. A little bit about Professor Joanne Potterton. She is an associate professor in physiotherapy at the University of Witwatersrand. She is responsible for teaching pediatric physiotherapy at undergraduate and postgraduate level. Her research interest is in pediatric HIV and its effect on child development. Joanne's research has contributed to understanding the complex interplay between HIV infection and social deprivation and the impact this has on infant and child development. Joanne has supervised numerous postgraduate students at master's and PhD level, has presented and has published her work nationally as well as internationally. Under this category, we also have Dr. Natalie Benjamin-Damons. Dr. Natalie Benjamin-Damons is a senior lecturer in pediatrics in the Department of Physiotherapy at the University of Witwatersrand. She's responsible for teaching pediatric physiotherapy at under and postgraduate level. Natalie's area of specialization is in childhood development and gait patterns in CLHIV and how it affects development and learning in children older than 3 years of age. Natalie's research has contributed to understanding how HIV affects the peripheral nervous system of CLHIV and the impact it has on development and motor ability. The last person we will be introduced to underneath this category is Nicolette Comley-White. Ms. Nicolette Comley-White is a lecturer in physiotherapy at the University of Witwatersrand. She's responsible for teaching adult neurology at an undergraduate and postgraduate level, as well as supervising postgraduate research at a master's level. Her area of special interest is in stroke as well as HIV, and she is currently a PhD candidate with her research focused on HIV and adolescence. The last category this session will be looking at is knowledge translation, and our author and lead presenter here is Professor Hellen Myezwa. The title of her research that she'll be going over with you guys is Knowledge Translation, HIV Advocacy Through Education. A little bit about Professor Hellen Myezwa. Professor Hellen Myezwa is a full professor at the University of Witwatersrand. She is the current head of the School of Therapeutic Science. Her area of research is research in adult HIV disability, which is an area of research that contributes to understanding rehabilitation for a condition that largely affects 25% of South Africa's population. This field of physiotherapy research focuses on understanding the full spectrum of the HIV trajectory through a rehabilitation conceptual lens, from the epidemiology of the disability to prevention, treatment of care, support, and policy implications that are in line with the national approach to HIV management. The last person we will be introduced to underneath this category, our very last category, is Dr. Adedayo Tunde Ajidahun. Dr. Ajidahun is a postdoctoral research fellow at the University of Witwatersrand. His research specialty is in neuromusculoskeletal systems, injury prevention, disability, and health promotion. His current research is focused on developing intervention programs in managing some identified HIV-related disabilities. You are now going to move on to the research I just spoke about and the people I also introduced. I hope you have fun, I hope it's informative, and I will see you at the end of the session. Bye.
The focus of my study was on knowledge and behaviour regarding HIV/AIDS among persons with disabilities in Gauteng, South Africa. South Africa is one of the countries with the highest HIV prevalence, and among the most affected population groups, people with disabilities have been identified as a high-risk group needing targeted intervention. Sadly, the impact of HIV/AIDS on people with disabilities has not been given enough attention, as they are wrongly perceived to be asexual, thus at no risk for HIV infection. Risk factors that are associated with HIV infection among people with disabilities include poor access to sexual health and HIV services, engagement in risky behavior, sexual violence, and unemployment. The aim of the study was to determine the level of HIV/AIDS knowledge and the sexual behavior practices of persons with disabilities in the city of Tshwane, Gauteng, South Africa. The study used a quantitative descriptive study design. The setting of the study was at a non-profit organization for people with disabilities. Participants were all consenting persons with disabilities who had physical or visual disabilities, and convenient sampling was used to recruit the study participants. Questionnaire with questions on HIV/AIDS knowledge and sexual behavior practices was administered by the researcher. SPSS software was used to analyze data. Descriptive statistics was conducted to produce frequencies and percentages. Chi-square test was used to measure the association between HIV/AIDS knowledge level and risky sexual practices. Now let's look at the results. 55% of the participants had excellent level of HIV knowledge, while 17.5% had good level of HIV knowledge. Lastly, 15% had poor level of HIV knowledge. We are now looking at the results for sexual behavior patterns. Approximately 85% of the participants were sexually active. 60% of those did not use a condom. 48% had multiple partners, and 24% used alcohol before they engaged in sexual activity. Now looking at the association between knowledge level and sexual behavior, there was no relationship between the level of HIV/AIDS knowledge and risky sexual behavior choices. In this study, we found that 73% of the participants had good to excellent levels of HIV/AIDS knowledge. And this is contrary to what has been reported in literature, that people with disabilities have low levels of HIV knowledge. This is good because it indicates that HIV/AIDS message is reaching people with disabilities. Secondly, the majority of the participants engaged in risky sexual activity. This finding supports what has been reported in other studies. People with disabilities engage in risky behavior, making them vulnerable to HIV infection. Lastly, the main concern from this study is that good knowledge level does not necessarily translate into safe sexual behavior in people with disabilities. In conclusion, although the majority of the participants had good to excellent levels of HIV/AIDS knowledge, this did not influence risky behavior choices. It also shows that sexual behavior is not only influenced by HIV/AIDS knowledge, but by other risk factors. There is a need to develop interventions targeted to people with disabilities that address the drivers of risky sexual behaviors. I thank you.
Good morning. I'm going to provide some information regarding the importance of encouraging movement and physical function to influence potential disability in people living with HIV and AIDS. My name is Ronel Roos, and I'm an associate professor working at the University of Witwatersrand in Johannesburg, South Africa. HIV is a significant sub-Saharan Africa health problem, and we know that 6 comorbidity clusters are known to influence health in people living with HIV and AIDS. Those clusters are cardiovascular disease, metabolic disease, respiratory disease, cancer, mental health issues, and then also sexually transmitted diseases. The United Nations Sustainable Development Goal number 3 aim to ensure healthy lives and promote well-being for all at all ages by 2030. Due to the chronicity of HIV, a proposal was made that the treatment approach should be 90-90-90-100 strategy, where 100% of services link chronic care to rehabilitation. Physiotherapy has a role by implementing health promotion strategies and implementing curative and rehabilitation strategies to influence and reduce disability in people living with HIV and AIDS. In 2030, we undertook a study where we evaluated the physical activity levels of individuals living with HIV and also assessed their physical activity preferences. It was an observational study done at an urban HIV clinic in Johannesburg. Physical activity was assessed with the Yarmux pedometer over a 7-day period, and participants were also questioned regarding the activity preferences that they implemented in their daily lives. The study identified that physical activity levels were reduced, indicating by the reduction in pedometer steps, and it also highlighted that the majority of participants were sedentary or following a light, active lifestyle. 8 individuals reported that they did formal sporting activities such as participating in club soccer, where the most initiated some form of exercise in their daily lives. Walking and running were most frequently reported. The implications for this for physiotherapy is that physical inactivity was present in the majority of the sample studied, but findings illustrated that individuals were motivated to be more active by implementing self-initiated forms of exercise in their daily routine. The follow-up study that we did was to investigate the physical function capacity of individuals with the 6-minute walk test in, again, an urban cohort of people living with HIV, and to determine whether a history of pulmonary tuberculosis and whether the anthropometric measures, age, and gender predicted the distance that they could walk with the 6-minute walk test. We did data analysis of secondary data from an existing database of 84 individuals that were on antiretroviral therapy. The study highlighted that age, gender, and anthropometric measures such as BMI and waist circumference were associated with the distance that individuals could walk with the 6-minute walk test, but the associations were of low to moderate strength. The regression equation generated included age and gender, and this model was significant and accounted for 34% of the total variance observed. The clinical relevance of the study. The current study highlighted that a previous medical history of pulmonary tuberculosis was not predictive of the 6-minute walk test distance that individuals could walk, but age and gender were. This is quite relevant considering the high prevalence of TB in South Africa. Then the 6-minute walk test predictive equation generated is illustrated on this slide, and individuals implementing rehabilitation programs where 6-minute walk test is an outcome measure can use this equation to predict the sample's distance walked. Further research is, however, needed to validate the specific equation in the African region. During the study, participants tolerated the 6-minute walk test, and no unfavorable results were identified, and this illustrates that this exercise test is a safe exercise test to implement in the population. Due to the high levels of physical inactivity, we implemented an education and home-based pedometer walking program in individuals as a means of evaluating the effect of such a program. It was an intervention study by means of a randomized controlled trial where we had 42 control participants and 42 experimental participants. The experimental group received education regarding ischemic heart disease, the benefits of following an active lifestyle, They were also educated on how to monitor their physical activity, and a progressive pedometer walking program was implemented in this group. The control participants continued with standard care at the clinic and were phoned every month to determine if they still live in Johannesburg and to determine if they are experiencing any health issues. Assessments were done at baseline 6 months and 12 months, and the intervention study was conducted during baseline to 6 months, and during 6 to 12 months, the intervention participants continued with the education and walking program independently. The program illustrated that there was an improvement and steps taken by the intervention group. There was also an improvement in the exercise capacity and the distance that they could walk during the 6-minute walk test. There was a slight reduction in waist-hip ratio and also glucose values, and an improvement in high-density lipoprotein. So the study illustrated that education and home-based walking program monitored by a pedometer could be effective in improving exercise capacity, walking habit, as well as some aspects related to ischemic heart disease risk factors. Activity is often influenced by barriers and facilitators, and we wanted to investigate what the specific barriers and facilitators are in study participants who were following a home-based exercise program in South Africa. Qualitative content analysis of participants' physical activity diary entries were done to highlight what were the barriers and facilitators. We found that the barriers to physical activity were multifactorial and often contextual, related to the environment that the patient lived in. And it's also very important to note that the physical and social environment pose unique challenges that needs to be considered when constructing and implementing a home-based physical activity program in a low socioeconomic population such as sub-Saharan Africa, to ensure that participants are safe when conducting the home-based exercise program, and also to ensure that adherence is achieved with such a program. HIV is a chronic disease where individuals can experience episodic disability when they fluctuate between periods of wellness but also illness. So in this study, we specifically wanted to describe the physical and functional impairments of patients with active TB when they are admitted to an acute care hospital. It was a prospective observational longitudinal study where individuals were assessed in hospital, then again 6 weeks following hospital discharge, and 6 months after hospital discharge. The study highlighted that there was a high dropout rate and also mortality rate in patients with active TB that required hospital admission. We also highlighted that there was non-significant changes in the muscle architecture and also muscle power over the 6-month period when participants were followed up. And we identified that patients often presented with balance impairments. They also had reduction in exercise capacity, and there wasn't significant improvement in the exercise capacity over the longer period between 6 weeks and 6 months. So this study highlighted that the need for pulmonary rehabilitation is necessary, specifically after hospital discharge, to improve the physical function in individuals when they are recovering from acute TB. Individuals can also be acutely ill and require ICU admission. So with this study, we aim to describe the physical outcomes of ICU survivors that are HIV positive in a high prevalent area. It was a longitudinal observational study where individuals were admitted to a general ICU in Johannesburg, South Africa. Participants were assessed at ICU admission, ward admission, hospital discharge, and again 3 and 6 months after hospital discharge. The outcomes that we used were the ICU mobility scale, the Konofsky performance status scale, the MRC sum score, as well as we assessed respiratory muscle strength, and we assessed quality of life with the EQ5D. The results again illustrated that when individuals were acutely ill, requiring critical care management, mortality rates were high. In the sample that survived, ICU respiratory and peripheral muscle weakness were present that influenced their physical function. Improvement in physical function occurred over time, but most participants still had physical dysfunction at 6 months, and participants reported that pain or discomfort were common complaints influencing their quality of life. Again, this study illustrates that physical dysfunction is present in patients that required ICU admission, and again, rehabilitation strategies are needed to optimize patients recovering from the acute illness to lessen long-term disability. In conclusion, enhancing movement, physical activity, and exercise in the different sectors where physiotherapists work are beneficial to improve the health and wellness of people living with HIV. Due to the symptoms that individuals can complain of during such programs, these symptoms include pain, shortness of breath, fatigue. They should be monitored to ensure individuals are coping with the prescribed movement strategies. Then, if individuals are admitted to hospital due to acute illness, be that pulmonary TB or be that other conditions, physiotherapy is needed to treat impairments and physical activity limitations by initiating early rehabilitation programs. It is very important that these rehabilitation strategies do continue after hospital discharge to improve quality of life of individuals and also to reduce long-term disability. If you would want to contact me for further discussion and input, this is my contact details. Additionally, these resources, specifically the physiotherapy resources, is available for your review for more input related to the material presented in this presentation. Thank you for listening.
Hello everyone, I am Precious Molousi. I will be presenting a study entitled Identification of Components of a Comprehensive Disability Rehabilitative Program for Adult People Living with HIV, a scoping review. This research report was submitted to the Faculty of Health Sciences at the University of Witwatersrand in partial fulfillment of the requirement for the degree of Master of Science in Physiotherapy. Next slide. Globally, 36.9 million people are living with HIV, and this is a figure that has been increasing gradually. In South Africa, people living with HIV are over 7 million. Although antiretroviral therapy has increased the life expectancy in this population, there is growing evidence of HIV-associated disability. However, evidence of a comprehensive disability management program is scanty. Next slide. The aim of the study. It was to identify the components of a comprehensive disability management program for people living with HIV. And the study had two objectives. The first objective was to describe the HIV-related disability, and the second objective was to identify the rehabilitative interventions for HIV-related disability. Methodology. The scoping review followed the Joanne Briggs Institute Scoping Reviews Manual. Two databases were used for the literature search. We used the Public Medline and the Cumulative Index to Nursing and Allied Health Literature. The studies that we were looking were conducted in multiple settings worldwide, done on adult people living with HIV. Methodological quality assessment of the studies was also done using the relevant tools. Next slide. The results. A total of 27 studies met the inclusion criteria. 13 of these studies described HIV-related studies, with the 14 studies investigated rehabilitative interventions. The International Classification of Functioning Disability and Health Framework was used to outline all the disabilities that were found. Next slide. The results showed that HIV infection affected multiple body functions. Under mental functions, depression and anxiety, fatigue, dementia, post-traumatic disorder, cognitive impairments, sleep disturbances, decreased self-esteem, energy, and drive functions were the common impairments that were reported. Under sensory functions, paresthesia and pain, pain such as headache, painful joints, muscle aches, abdominal pain, and chest pain were the most common. Under neuromusculoskeletal and movement-related functions, loss of muscle power, muscle and joint pain with joint stiffness were reported. Under functions of the digestive, metabolic, and endocrine system, weight maintenance, obesity, rashes, diarrhea, and diabetes. Patients who were on antiretroviral therapy were found to have body-related image issues, and they experienced weight maintenance problems. Most gained a lot of weight. The weight gain was around the stomach area. They had skinny legs, skinny arms. Impairments in the cardiovascular system and in the respiratory system that were found were cough and breathlessness and high blood pressure. Next slide. Activity limitation and participation restriction were noted in all the 6 domains of the ICF. Mobility challenges identified included walking, lifting, and carrying heavy objects. Under the domain of self-care, washing and dressing was a challenge. Under the domestic life domain, acquisition of goods and services, household chores, and preparation of meals, vigorous and moderate activities. Under the domain of interpersonal interactions and relationships, intimate relationships and formal relations, challenges were reported. Under major life areas, there were challenges with remunerative employment, economic self-sufficiency, and education. Under the community, social, and civic life, barriers in obtaining products for personal use was a challenge found in the studies. Next slide. The studies that reported rehabilitative interventions found two types of interventions that were evaluated to be effective in people living with HIV. The first intervention that had a high evidence was the exercise therapy. The exercise therapy included aerobic training, progressive resisted exercises, and combined training, which is your aerobic and progressive resisted exercise training in one training. The second intervention was massage therapy. One study, which was a systematic review, showed that massage therapy improved the quality of life and affected positive changes in immunological functions. But the massage therapy was done in conjunction with meditation and stress relief therapy. Next slide. In conclusion, the scoping review described HIV-related disability, with the key disabilities described using the ICF. The study further demonstrated how the respective impairments are linked to activity limitation and participation restriction, and their influence on the manner in which rehabilitation should be undertaken. For instance, a person with neuromusculoskeletal impairment, such as muscle weakness or joint stiffness, will present with a functional limitation, but the pathways to functional limitation will differ from those of a person with depression. Therefore, the knowledge of the different pathways of impairments resulting in functional limitation is very important for rehabilitation, as it identifies the point where rehabilitative interventions should start. Thorough assessments of patients will indicate the pathways that lead to disability. Lastly, what was very surprising was that there was no eligible studies that was found that reported on community-based rehabilitative interventions, although CBR is recommended in South Africa. The high prevalence of HIV in South Africa and the limited resources makes it very necessary for home-based and community-based rehabilitative interventions in this population. These interventions should include exercise therapy and massage therapy. Come to the end of this presentation. Thank you for listening.
In this presentation, we will be discussing some of the physical challenges which children infected with HIV may face throughout childhood, from infancy right up till adolescence. The work we present is based on a body of work which we have conducted through the Department of Physiotherapy at the University of the Witwatersrand in Johannesburg, South Africa. In this era of antiretroviral therapy, pediatric HIV is a multi-system chronic disease, and the children in our care are living much longer, healthier lives than before. Some of the systems which may be affected include cardiorespiratory, metabolic, neurological, and musculoskeletal. There are complex interactions between systems and the medications which are required. Comorbidities further complicate the clinical picture, along with potential neurotoxic effects of antiretroviral therapy. Children across the spectrum of childhood and into adolescence face physical challenges which may lead to long-term disability. These challenges may be present in infancy, childhood, and adolescence. In infancy, it is well established that HIV infection can cause developmental delay in all facets of development, particularly in gross motor development. While early initiation of antiretrovirals can help mitigate this delay, all infants infected with HIV remain vulnerable. HIV and ART exposure in utero may put infants at risk for developmental delay, even if they are not infected themselves. This area is still contentious and warrants further investigation. In the preschool years, developmental delay remains a challenge. Gross motor, fine motor, language, and visual perceptual difficulties may make it difficult for a child to keep up with their uninfected peers. Less research has been done on the challenges facing school-going children. Muscle strength, endurance, and gross motor function may all be affected, especially in children whose disease is not well controlled. In a study which asked parents to complete the 10-question disability screening form for their children, over 50% of children screened tested positive for at least one form of disability. Of those identified, only half were receiving appropriate rehabilitation. A high burden of gross motor dysfunction and manual dexterity, aiming and catching, but not balance problems were identified in school-going children. HIV sensory neuropathy occurs in 13% of children living with HIV, but was not associated with motor dysfunction. In adolescence, the effects of perinatal HIV is starting to emerge, but research still has a long way to go. Adolescents are presenting with decreased bone mineral density, delayed onset of puberty, stunted growth, neurocognitive delays, and mental health challenges. Other physical challenges which are emerging include pain, fatigue, decreased endurance, and poor motor performance. In summary, HIV has the potential to cause subtle disability even in well-managed children across all stages of childhood. Careful monitoring of the functional status and well-being of all children affected by HIV is essential. Although we know more about the impairments which children infected with HIV may face, we know less about what interventions work well. And so pragmatic, sustainable interventions need to be developed and implemented in the long-term care of these children. HIV has taught pediatric physiotherapists in South Africa not to wait for answers before responding to a need. By asking the right questions and being prepared to step up, we can have a positive impact in fields where our role is not yet clearly defined. We urge parents to be advocates for your child's physical health and well-being. Play with and talk to your baby. Ask for referrals to a physiotherapist, occupational therapist, or speech therapist if you think your baby may be delayed. Keep your children active and encourage them to participate in games and sports with their friends. We urge policymakers to include developmental screening of all infants exposed to and infected with HIV. Disability and motor screening needs to be done throughout childhood, and access to appropriate rehabilitation services for all children and adolescents affected by HIV is imperative. Children need safe neighborhoods in which to play. Please don't hesitate to contact us if you have any questions about our presentation. Thank you for your time.
Hello, my name is Hellen Myezwa, and I am one of the principal investigators on this project, which was carried out on knowledge translation, HIV advocacy through education. This is our research team, myself, Hellen Myezwa from South Africa, as well as my colleague Joanne Potterton, also from South Africa, and Tunde, Dr. Ajidahun from South Africa too. As a principal investigator, my co-principal investigator is Stephanie Nixon from Canada, and the other co-investigators are Brian Chiluba from Zambia, Moses Konje from Kenya, and Florence Omoro from Kenya as well. Much is taught on HIV throughout many curricula in universities and colleges for rehabilitation professionals, for occupational therapists, physiotherapists, nurses, and even doctors. However, no studies have been found in the literature that prepared students for knowledge translation. By definition, knowledge translation is a dynamic and iterative process that includes synthesis, dissemination, exchange, and ethically sound knowledge for a situation. And this knowledge, we know, is derived from research findings and essentially focuses on closing the gaps between what is known and what is carried out in practice. Recent literature has begun to really acknowledge the need to build capacity on knowledge translation, because it does not just happen as anticipated. The aim of our study was to develop knowledge translation that is designed to improve attitudes and self-efficacy in HIV and rehabilitation advocacy among our students in rehabilitation training programs. And as mentioned before, this was done in 3 sites, but for this study or this presentation, I will focus on the results from this. So the second objective was to tailor and implement the knowledge intervention within the physiotherapy curriculum at the University of the Witwatersrand in Johannesburg, South Africa. And thereafter, once we had implemented, to evaluate the effects of the knowledge translation, determining what works in building knowledge, attitudes, and self-efficacy related to HIV and rehabilitation among our students. The method was pragmatic and context-based. At WITS, HIV is already mainstreamed across the curriculum from the first year of study to the 4th year of study. The students were introduced to the project, and a lecture to cover the principles of advocacy was given, and consent obtained from the students as well as the institution to conduct the study. Patient cases were adjusted to include HIV in the clinical placements, and I will give an example of a case that was used in the study. The assessment tool used for assessing the verbal case, which is presented verbally, as the name suggests, across all the areas of teaching, was adapted to include a section on advocacy. And this was applied in all areas of teaching: cardiopulmonary, pediatrics, neurology, public health, orthopedics, and sports. 4 of these rotations participated in the study and had cases developed, and these were public health, pediatrics, cardiopulmonary, and neurology. And following the completion of the cases, each case was analyzed to establish the extent to which students advocated. The tools that we used to also assess the students' knowledge, the students' attitude, and the students' self-efficacy were also conducted pre and post the intervention. This is an example of a case that the students might have gotten in, for example, the public health urban block. In this case, they were in the community, and the case stated that the prevalence of HIV is high in these communities, and these communities are typical mixed urban communities with informal and formal settlements. And their task was to identify a target group where screening for HIV disability among HIV positive individuals was required for either adults or children. So it was really need based, and they had to establish this. And using resources such as the e-module that was developed, as well as other literature, they were to conduct their case with emphasis on the advocacy project aspect. These are some of the results, and we'll give you a short and sharp snapshot of what came out. We do have other results that refer to the qualitative aspects that the students experience, so they share their experience and what they learned. But these are more the quantitative results because there's not enough time to share everything. The socio-demographic characteristics of our students show here that their mean age, of course, being university students, was 21.43, and we do have slightly more females within our programs, and slightly more females participated in the study than males. And we focused on the third and fourth year students. And because this was not a compulsory participation, our numbers differ pre and post, but they are still relatively high numbers that participate. In terms of experience with HIV advocacy and the history thereof for our participating students, we established in terms of their HIV advocacy history, we checked if they had worked with people living with HIV before, and just slightly over half pre this project had worked with people living with HIV. Not many knew someone personally, and also just about 30% had had any experience with advocacy. And of course, this changed quite a bit, especially in terms of having worked with people living with HIV and having had the experience to advocate. In terms of the knowledge, we compared the knowledge of students before we implemented the knowledge translation project and compared to post-intervention. And as you can see, the results show a significant difference in the area of their ability to describe health and disability challenges. And this was shown to be significantly different using McNeema's test for all of them. The students also showed a difference in knowledge on resources that exist in the community. And these would be resources they can use to help with health and disability challenges for people living with HIV. Similarly, students felt that they understood better how to advocate on behalf of patients where necessary, and with patients where it was applicable. There wasn't a significant difference in how students understood public policy to impact the health of people living with HIV. And this is not surprising because of the level at which these students are, which is senior students in an undergraduate degree. And often policy, as you may all well understand, requires you to have a significant amount of experience before you can actually engage in policy. In terms of the students' attitude to advocacy, it was interesting that they had a very good attitude to advocacy for HIV patients. And therefore, there was not much difference in their attitude and how they perceived themselves to engage with HIV issues, and therefore we were not able to conduct any tests for difference between the pre and post status. In terms of self-efficacy, it was interesting to see that there were significant changes in confidence, being a resource person, being confident to facilitate access to the community, and also confident to access information to manage the health of patients living with HIV. And finally, there was a difference in the confidence in terms of the skills to advocate for a population or a system level change on behalf of people living with HIV. And this was also evident in some of the cases where students themselves felt confident to go and negotiate if they felt, for example, that resources were not adequate in a particular area of the clinical practice where they felt that the patients they were dealing with needed the intervention of a particular service. So the relevance and implications of this is that students responded positively to the explicit inclusion of advocacy in the curriculum. And only 50% of, although only 50% had worked with HIV patients before, and with 30% knowing anyone with HIV or experience with advocacy, after intervention, they showed a significant difference in knowledge in relation to health and disability challenges and the resources available and how to advocate. They also showed significant differences in confidence with clinical skills, being a resource for others and facilitating access for people living with HIV, and accessing information and advocacy skills for their work and to ensure that they could make a difference in what they were doing. So in conclusion, with knowledge translation, it's possible to shift the status of intervention from just test and treat only to enhancing survival and thriving. And in our qualitative results, there are examples of how the student felt that they had gone beyond increasing range of motion or improving strength to actually making a patient feel that they had resolved a particular issue and were able to go on and be fully effective in the function of whatever the problem was. We believe that this study contributes to the knowledge on how to translate research findings in the practice space, and in this case, the practice space being education for future healthcare workers. And this will make a significant difference once each of these students have qualified and are working in any situation. Thank you for listening, and I trust that if you need more information,
we and I'm the corresponding author, and these are my reference contact details. Thank you.
Welcome back. We are at the end of our first session for the Disability Networking Zone, which largely focused on research. I hope the session was informative. I hope it was fun. I hope you got knowledge on the kind of research that's being done in South Africa and where our researchers are largely focusing their attention towards. I would just like to say a special thank you to all the researchers that partook and that took the time to give you guys a little bit of a perspective into their research. I'd also like to say a big thank you to Professor Hellen Myezwa. She was the one that rallied up all the researchers you got to meet today. So big thank you to her. This session would not have been possible without her. As you would have seen during this session, our researchers did leave with you guys their contact information. However, if you did not get the chance to get their contact information, under resources, we have a contact list. Here you will find all of our researchers and their contact details. You will also find the Disability Networking Zone contact information. So the other organizations that are part of this zone, their contact information, their website, things like that. If you do have any questions for our researchers, feel free to ask questions during our live chat sessions. We are more than happy to interact with you guys to see kind of where your head is at, if you want more information, what kind of questions you want to ask us. So feel free to do that. We are more than happy with that. Lastly, I just want to say, be sure to check out our other session programs. They are very interesting, they're very interactive and fun. Our second session is titled Wellness Importance within the context of health screening and testing. And this largely looks at a social and behavior change program that targeted people with disability and HIV here in South Africa. Session number 3 looks at gender-based violence and women with disabilities. And as we know, gender-based violence has a close link to HIV incidents. So that session is extremely informative, it's extremely fun, so go and check that one out. Session 4 is inspiring the response to COVID-19 with the journey and lessons learned from HIV and disability. So this session is largely looking at the journey it took in understanding HIV and disability and how we can kind of apply this to our now big issue, COVID-19. Our last session, which is the most fun session of all, it is a nice session to end off with, an interactive session. It is titled Unconventional Convening on Disabling Issues of HIV. There are songs in one of our native languages here in South Africa. There's a reading by children. There's also, however, a scientific panel that largely looks at rehabilitation, and it ends off with an interactive, fun exercise that everyone can do, especially people with HIV and disability. So be sure to check out the Disability Networking Zone other programs. Be sure to check out our resources. We have also left a lot of the research articles and important and informative resources that you guys can go through, you can share. Yeah, other than that, I hope you enjoyed our session and have a good day. Bye.